Great. Thank you very much. That was an excellent talk, Anthony. I'm privileged to follow, and I'm going to be building on some of the concepts that you mentioned, actually. The learning objectives here are to understand cutting-edge clinical trial data involving the drug Sotatercept in particular, understand early clinical study data supporting the therapeutic pipeline for PAH, and learn fundamental principles in translational science that focus on therapeutic discovery. And I think that we find ourselves at a moment in time where understanding how treatments that are available and being used for our patients have affected their long-term survival and their quality of life in a way that may not have been done previously. We really are trying to get as much information around what it is we do and how that affects our community of patients. So on the one hand, we have a line of data suggesting from observational studies in the current era with the availability of pulmonary vasodilator therapy, particularly more recently where multiple drug therapy use is more common, that outcome is reassuring, that we have a measure of optimism to offer our patients in clinical practice. On the other hand, there are also emergent data suggesting that we have a long way to go, that even in the contemporary era, we have an unacceptable mortality rate following diagnosis. Here, 3-year mortality of 30% has been advanced. There are emergent data suggesting that we really haven't seen a true increase in lifespan despite the availability of medical therapies that we use day to day. We know from the AMBITION trial that's been discussed earlier that almost a third of patients have an event of some kind within 500 days, even under really well-controlled circumstances like a randomized clinical trial. So there's no question that we have a lot of work to do. We have 14 FDA-approved drugs that target 3 functional pathways. The goal, of course, is to address with greater precision the heterogeneity on a molecular and phenotypic level that overall conspire to cause the severe remodeling pattern that we know defines, in principle, the disease pulmonary arterial hypertension. And we also know that we have a number of critical pathways that may be candidates for effective therapeutic development, but we need more information and we need to make headway into understanding how to drug them and what the best strategy forward is to ultimately deliver back to the clinical operation. And so with that in mind, the question of what's in the pipeline is always a very exciting one and a critical one that we need to be thinking about because it sort of is a window into the future and where we stand. It's also a really challenging topic to boil down into a single discussion because a lot of different therapies are at different stages. And although some may be promising in an experimental line, we also need to take heed that translating that to clinical practice can be challenging. And so what I'm going to try to do here is to drill down on 3 different therapeutics, each at totally different stages of the therapeutic development pipeline. Focusing first on Sotatercept because it's the most advanced among the ones that I think are promising. We'll also talk about bromodomain 4 inhibitor therapy, and then I'll just give a brief vignette from some of the work we're doing in my own lab and provide a little bit of a window into sort of the mechanics of drug development. So this slide shows on the left side of the panel the cover page of experimental data that demonstrated from Paul Yu's lab, who's a friend and colleague of mine, the mechanism by which inhibiting activins and GDFs through a ligand trap, which we now know today to be a form of Sotatercept, is effective at mitigating and decreasing various components to the vasculopathy of PAH, including fibrosis and hypertrophic remodeling. On the right side is a very helpful figure from Mark Humbert and his group that conducted the Pulsar trial, and I apologize if there are people that were involved directly in the trial in the group. If I make any errors, please correct me. But the function of this figure, of this cartoon, is to provide a schematic that helps to articulate why the pathway that sotatercept targets is potentially important. So on the top panel of this cartoon, you see conditions akin to PAH in which overactivation of the SMAD2/3 signaling pathway through the activin 2RA receptor complex is associated with inhibition of the anti-proliferative effects of the BMPR2 pathway through gremlin and noggin. And the idea here is that sotatercept binds, it soaks up activins and GDFs that otherwise stimulate this activin 2RA receptor pathway, and thereby may offer rebalancing of these two receptors that are each in and of themselves implicated through a number of different experimental lines of evidence as being pathogenic in pulmonary arterial hypertension. And so this was a really important trial in many ways. Maybe perhaps the most important, beyond the very exciting clinical trial results, is that it was a very large phase 2 trial, and in some ways sets the tone and maybe even the bar for what we can expect for optimized phase 2 studies to avoid failing at that critically vulnerable transition point from phase 2 to phase 3. So this phase 2 double-blind placebo-controlled trial took place over 24 weeks and involved 106 patients that were randomized to placebo or 2 different doses of sotatercept, with the primary endpoint of pulmonary vascular resistance change from baseline being advanced here as a measure of disease remodeling, and therefore any salutary benefits of the drug could be implicated as disease modifying. You can see the clinical profile of the study cohort in the form of demographics, the PAH, medical therapy, the clinical subtypes, and the hemodynamics, all very consistent with what I think we're accustomed to seeing in clinical trials of this scale that are done on a multi-center basis. And the results were very compelling. You can see, compared to placebo in yellow, that the change in PVR followed a dose-response pattern in which there was an average reduction at the end of the study compared to beginning of about 256 dynes per second per centimeter to the fifth. And this is a very important reduction in PVR that is in line with a strong clinical benefit, and that this was observed overall as significantly different compared to the placebo group. And you can see the PVR resistance at baseline and at week 24 from the placebo-controlled period in the panel B that provides these data or presents them a little bit differently. Of course, with the advance of any new first-in-class for a different disease, we really want to be focused on safety first. And here you can see the adverse event rate table from the trial. And I think there was consensus among most of the people that were thinking a lot about the study results that this was generally a well-tolerated drug that followed a very familiar pattern in terms of event rate, at least in the Pulsar study that we have to date. And so I think, although there was a lot of concern about hemoglobin and other hematologic consequences, we didn't see that in a prohibitive way. One of the important side effects that we'll talk a little bit about more is this issue of Teleinjectasia, which is a vascular anomaly that can occur in the context of drugs that affect the TGF-beta signaling pathway, which is what Sotatercept does. And in fact, if we look a little bit beyond the initial Pulsar trial to the open label extension sub-analysis of that initial study, you can see sort of how the patients that were initially randomized followed through. There were 32 initially placebo-assigned patients that were then randomized to Sotatercept, and then there was a subgroup of patients in the initially randomized Sotatercept group that continued therapy. And what we saw here is that the patients that were initially randomized to placebo and then moved to Sotatercept demonstrated a very similar treatment effect size as those that we observed that were initially randomized to Sotatercept in the initial Pulsar data set. Among those that were continued long-term on Sotatercept, we saw a sustained benefit in PVR. There didn't seem to be much of a further reduction, at least by months 18 to 24. And so I think this is an important finding that we need more clarity, probably from the phase 3 data to reconcile, and then ultimately in our own clinical practices about how to leverage these kinds of expectations when we counsel patients in the clinic about what our expectations are for any drug, including Sotatercept here. So I think that important sort of treatment-associated effects were identified in about 31% of patients, which is notable. The special treatment-associated effects included teleinjectasias, as I mentioned, in about 11% of patients. So exactly what the functional significance is of this, what the clinical implications of this, we need a little bit more information and probably are going to need firsthand experience in clinical practice to ultimately resolve whether or not this is something that would affect in one way or another how we approach the use of Sotatercept for our patients. And I think we're going to see a lot more information around this with the forthcoming studies that include other clinical trials as part of the Sotatercept program, which was a really unique and very comprehensive launch by the team that was advancing this as a potential treatment. So we look forward here mostly to the stellar treatment data, which should be forthcoming, I would imagine, in the next 6 to 9 months, just based on preliminary press release information. So transitioning to bromodomain-containing protein modulating treatments, which is the second of the 3 drugs that I wanted to talk about, we move to a drug that's in a different phase of its advancement. This is a pathway that we know is important in PAH. Bromodomains are genetic erasers, which sounds pretty scary to me, but in any case is identified as an important epigenetic modifying pathway that increases 2 oncogenes, survivin and BCL2, to disrupt the balance in cell survival and cell death, ultimately through a number of lines of work, including from Sebastian Bonnet's lab and others, that this is a modifiable target in experimental PAH through bromodomain 4 targeting treatments. And so this set the stage for the testing of apabetalone, which is a known and well-studied BRD4 inhibitor in other forms of cardiovascular disease, that was trialed in an open-label, single-arm, 16-week study involving 100 milligrams of therapy twice daily, added to guideline PAH treatment. And the phase 1 study endpoints were very clear. They were baseline, 16-week assessment. Let's get as much clinical phenotypic data as is reasonable and test the endpoints first of feasibility and change in PVR as an exploratory endpoint, since this was not in and of itself powered statistically to look at changes in any specific hemodynamic parameter like, for example, the Pulsar trial was. This is the demographic and clinical profile of the study cohort, again, very much in line with what you might expect. These are patients that have moderate to severe pulmonary arterial hypertension, who have a 6-minute walk distance that's maybe perhaps somewhat preserved compared to some of the other studies that we've seen in the literature, but nonetheless very consistent with what we would expect at the outset. And I think smaller studies give you a little bit of an opportunity to present data that can be a little bit more informative at the same time. This is the patient-level change across many different parameters that you don't really get a chance to appreciate in bigger studies, and this can be helpful to understand exactly what the overall trend was. You see a lot of consistent findings in the form of internally stable changes in PVR, within patient changes, and then in the overall cohort you can appreciate that on average there is a substantial reduction, and that this is overall in line with some of the other hemodynamic parameters that we would come to expect. And so when you summarize the results, there's an average change in PVR of about 2 Wood units. There was a delta cardiac output increase of about 0.7 liters per minute, and that we saw some evidence of biomarker changes that were consistent with the treatment pathway that's being targeted by the bromodomain 4 treatment. And so overall, providing a number of very encouraging parameters to warrant further investigation. It was tolerated well by the patients in the study. There were 2 that had an asymptomatic rise in their transaminase level, but this didn't prohibit further participation in this small study. The approach 2 is the phase 2 study that's underway, as my understanding, and so I think we can all look forward to knowing a little bit better about what the potential opportunities and limitations of this particular bromodomain for medical therapy is. And I think also leveraging off of other experiences in other diseases is very important. It gives you a leg up on anticipating potential side effects that might be prohibitory for our PAH patients in particular. So in the last phase of this study, I was going to talk briefly about some of the work we've done using network medicine to identify novel therapeutic targets. In this particular effort that was led by George Alba in my lab, we were interested in identifying hypoxia-sensitive proteins that might be druggable to prevent thrombosis, which is important in pulmonary arterial hypertension and also, of course, in chronic thromboembolic pulmonary hypertension. And we launched a network of medicine analysis in which differentially expressed genes from pulmonary endothelial cells treated with normoxia or hypoxia for 24 hours were analyzed further for functional protein-protein interaction pathways. And in this analysis that was enriched for gene sets focusing on fibrosis, which is important in clot formation, as well as after enrichment for pathways that focused on thrombosis, which of course is important for clot formation. We identified the protein and docking substrate Net9, which became consistent with some of the work we had done previously and was therefore a target of our further investigation. And when we looked more clearly at the effects of hypoxia on Net9 expression in cells, we observed that its expression profile seemed to be limited to the plasma membrane. We tested this in a number of different ways, and also identified an important interaction between Net9 on endothelial cells and P-selectin, which is the protein that's expressed on activated platelets, which are increased in PAH and increased in CTEPH. And so we sequenced the Net9 peptide sort of area where P-selectin binds to Net9, and then developed an antibody against that sequence by injecting New Zealand white rabbits with the peptide sequence and harvesting their antibody response directed against this Net9 peptide. And when you administer this antibody to cellular disease models, it's clear that it seems to inhibit platelet endothelial adhesion in control cells as well as in cells isolated, in this case, from chronic thromboembolic pulmonary hypertension. And the administration of the antibody prior to infusing ADP to activated platelets through the right internal jugular vein of mice shows a benefit against pulmonary artery pressure rises that are caused by acute thrombosis or pulmonary embolism. And that matched a number of different supporting pieces of data. In a chronic thromboembolic model where we sort of regularly administered the antibody after also subjecting the mice to microspheres that were dipped in thrombin to create a prothrombotic environment in the lung, we were able to demonstrate that the antibody inhibited thrombus and thrombotic remodeling using a number of different methods. And so this set the stage for trying to advance this a little bit further. We've just completed the first round where we've re-injected and boosted mice with the Net9 peptide, isolated their spleens, extracted the DNA from the B cells, and then used that to identify 20 clones that have been sequenced and tested against a negative control. And now we're in the process of ex vivo testing the development clones and seeing whether or not there's justification for moving forward towards humanization. And so I present this not to sort of kind of focus on my lab, but just to provide kind of a robust spectrum of where drug target and target development falls. And on the one hand, we have Sotatercept that's advancing to phase 3 studies and is, by all intents and purposes, going to be a very important and significant addition to our armamentarium. We have the bromodomain 4 story, which is based on experimental data and transitioning from a successful phase 1 to a phase 2. And then we have a very early stage story that may or may not become helpful to our overall mission of improving health in human disease for pulmonary hypertension. So in summary, PAH remains highly morbid with substantial disease burden. There's molecular heterogeneity, which in some ways is confusing and tends to put people to sleep in a basic science talk, but is really a huge strength and opportunity for us because it suggests that there's a lot of different pathways that can be leveraged to prevent or reverse remodeling. The PAH drug pipeline is busy, it's long, it includes a number of promising candidates that are at different phases of the sort of path to FDA approval. And I think the current focus is on Sotatercept in its phase 3 trial, which if successful would mark the first new druggable pathway in PAH that's approved in over 15 years. So really exciting time to be involved in PAH drug development, PAH treatment, PAH risk stratification, and I'm glad to be part of that. So.